So my section is just really to discuss the use and the results of our center's perspective using these products and how we've incorporated them into our clinical practice. These are my disclosures. I'm on some advisory boards for pharma, and those are listed on this slide. So I first want to show you where I'm from. So for those of you who are not from the U.S., this is Indiana. For those of you who are from the U.S., you might not know where Indiana is either, depending on where you're from. So if we look at our state, we follow the whole state. So this is our distribution of patients with bleeding disorders that we follow. And this is our center. So the objective today is really to describe the methods to extend the half-life for hemophilia treatment products, to discuss how we prepare our HTC staff and patients for these new products when they come out, talk about some considerations when making these treatment decisions, and then we have some scenarios that I'll touch on. So what is the value of prophylaxis? The value of prophylaxis is that really we hope that it prevents the long-term consequences of hemophilia. And how do we do that? We hope to prevent musculoskeletal and functional abnormalities. We hope to decrease pain and suffering in our patients, to improve their academic achievement by just being able to attend school on a regular basis and really attend to the instruction while they're there. To avoid future workforce limitations, to decrease inhibitor development, and hopefully reduce CNS bleeding frequency. So as we look at these new half-life products, or new extended half-life products, so how do you extend a half-life in general? You may use a naturally occurring pathway, such as Fc fusion protein or albumin fusion protein, or maybe increase the binding capacity to von Willebrand factor. There's also pegylation, which is taking a factor VIII protein and adding the chain, and then that is then cleared through the kidneys. So let's just really look at standard dosing and what the impact of these new products are. So if we looked at factor VIII, the general recommendations is every other day dosing, or 3 times a week dosing. And with the new products that are out, the recommendations really can now get you to every 4 days or to twice weekly. Factor IX, prophylactic, using standard therapy, is really twice a week dosing. And when we look at the extension of the half-life of the factor IX products, we're really seeing a big impact based on the package inserts. You're either being able to go every 7 days, every 10 days, or even up to every 14 days. And we do want to continue to keep in the back of our minds that young children have shorter half-lives and lower recoveries. So when we look at a lot of these extensions of half-lives, the ones that are really far out are usually on the adult side. So our IHTC experience, we have over 100 patients on these prolonged half-life products, both factor VIII and factor IX, and we've really learned a lot of lessons along the way. We've had to modify our approach based on these lessons. You know how it is, you jump in and then you figure out what you should have done before you jumped in, and then you go back and you modify how you're doing things. Also developing some educational materials based on those needs, and really with the understanding that each patient's situation is unique and everything needs to be individualized. So as new products come out, we do a two-pronged approach. We educate staff, the people that will be talking to patients about these products, and really by education, reviewing the published literature, and then thinking about what questions that we commonly know that our patients will ask, and preparing staff for the answers to those questions. And then the last thing is really, although all of the staff is educating, having some key people who maybe have a little more in-depth knowledge that can answer those very specific questions that patients have. From a patient standpoint, we develop a patient notification letter. So for any new product that comes out, for example, a new factor VIII product, the notification letter gets sent to the factor VIII patients. And we do that with every new product that comes out. And then we may have, based on specific individual patients or some attribute of the product, we may identify specific patients that we talk to directly. And really, the whole effort is aimed at making everybody feel comfortable with the new products as they come out. So the one thing that people are always talking about when extended half-life products come out and the topic comes up is really looking at PK analysis. So do I need to look at your specific response to product, and how would I do that as I change you to a new product? We know that, there's extensive PK studies done as the drugs are being in clinical trials. We know that an individual's pharmacokinetics, or how they metabolize the product, is really stable over time for that individual. And we have a pretty good idea that most patients that seem to have higher PKs on one product will probably have the same type of response to that new product. And then, can a modified pharmacokinetic study be used? I mean, I think each hemophilia treatment center has their own protocol. I'm not going to really comment on those, but I can tell you what we do at our center. So usually when we have a new product and we infuse a patient in clinic, we want to get a recovery, and that can either be at 15 minutes after their infusion or 1 hour. And one of the things that's going to give us a better idea about is, how is this patient going to respond to the product when they're bleeding? How do we know how much to give them during a bleeding episode? If they're on prophylaxis, we may also evaluate a trough, so the lowest their level would be before their next infusion, and that's going to give us an idea of what their prophylactic dose is and where we want to target. But we may do more time points than that. That's just kind of a general rule for our patients, and it's really based on specific clinical history of the patient. So when we talk to the patients, one of the things we're going to do is really review the patient and their specific needs. What do they want out of their treatment? What are they comfortable with doing? If we have a patient, for example, a severe patient that's on on-demand therapy, we're really trying to figure out what's the obstacles to prophylaxis for that patient, why are they on an on-demand regimen, and talk about how, maybe going on prophylaxis might be an advantage for them, really by knowing what interval would they desire. So if we could infuse you, every 4 days, is that okay? Or every 14 days, would that be something you'd like to do? From the patients who are currently on prophylaxis and transitioning to a different product, what we're going to look at is, where are they at now? Are they stable in their product? And if they are, what's the frequency, what's the dose, and is it effective? And then providing the patient about alternative approaches. So, do they maybe start out at every 7 days for a factor IX product, and then once they feel comfortable using that new product, could we go out to every 10 days or every 14 days? And really looking at our infusion schedule based on their activities. So if it's a child who's very active on the weekends, we want to make sure that they have good coverage for the weekends, and maybe modifying our approach based on the patient's schedule. We also talk to the patients and families about what their desired regimen is, about prophylaxis, how to treat bleeding episodes, current inventory and expected utilization. So what we want to say is, if somebody's going to change to a new product, we really want them to use up their old product before that change occurs. Which then can make it, depending on what they have at home, it can delay their start of the new product. So really working with the patient to develop the best time to do that transition to a new product. And then also looking at, is the reconstitution device different? Are the doses going to be different? And working with them. So transition touch points. So as we transition a patient to a new product, what we found over time is definitely we're going to educate them about the new medication and the mixing device. We may do the first infusion in clinic. If we are going to do that, the laboratory evaluation we may consider at that time after that first infusion is, again, looking at the recovery that I talked about, and then making sure we have we may do an inhibitor depending on the patient's history, and we may just store some plasma just to have in case something happens down the road. As we move forward, within 2 to 4 weeks after the start of therapy, we'd like to obtain a trough to see how their prophylaxis is doing. And at that time, we're talking about how have you been doing on the new product? Are you having any breakthrough bleeding? How are you feeling about it? And of course, if they are doing treatment logs, which we highly encourage, we'll review the treatment logs as well. During that first month, we found that having a weekly phone call is very helpful with the patients. And what we're doing with these phone calls is just really reinforcing dosing regimens, like what happens when you bleed. You know, we want you to call us when you have a bleed. Are you using the treatment logs? We're also identifying if they're having any type of reaction, assuming we would hope they would call us for any reaction, but it's a good time to touch base with them during that first month to troubleshoot questions. And then, you know, we may continue to contact that patient over time. It's just very individual at that point. But we really felt like the first month of a new treatment is very integral in really making them successful. And what we know is optimal isn't always practical. So for example, if we're used to telling patients to infuse in the morning, if they need to infuse in the evening, but that's the only way they can possibly do a prophylactic regimen, we're usually happy with that. So breakthrough bleeding, and that's always the biggest thing. What do you do with breakthrough bleeding on these products? So what we tell our patients to do is to call with every bleeding episode until we have a better idea of how they're feeling with the new product and that they're sure on how to properly use it. Usually the general guidelines for the patients for breakthrough bleeding, we don't really change their dosing, but the interval of follow-up doses will be different. You know, talking to them about every bleeding episode is unique, and the amount of follow-up doses will just really depend on the bleeding episode. And knowing that, just really reinforcing to them that this isn't the same product that you've been on before. So the last thing you want to do is call and find out that a patient's infusing every 12 hours with a factor IX product. So we want to talk to them ahead of time about that. So what's the impact that we've seen? For factor IX, it's been really big. I mean, previously on-demand patients have really agreed that, gosh, I'm infusing a couple times a month anyways. Starting an every 14-day prophylactic regimen seems pretty reasonable. We've had infusion schedules in children change from twice weekly to once weekly, which that really decreases the burden of disease. We've had a few active adults return to standard therapy. So they've gone to an extended half-life product, but then they decided to go back because they felt like that they didn't have the ability to infuse when they really felt like they needed it. Factor VIII, the impact isn't quite as great as in the factor IX therapy realm. We've seen kids with altered half-lives that were on every other day being able to extend out to every 3 days, which decreases the amount of infusions. We've had minimal or adults, young or adolescents and young adults who really have been on prophylaxis their whole life and have absent or minimal joint disease. Some of them have been able to go from every 4 days to every 5 to 7 days. We've seen adults with advanced joint disease who maybe the dosing regimen that they were on just didn't give them high enough trough levels. So although we kept their interval the same, we were able to get a little better trough factor level on them. We've had a few patients return to standard therapy based on some infusion, mild reactions with infusion. And then what we found over time from the standpoint of insurance documentation is it seems like the time when patients can pick whatever product they're on just because they want to pick it is going away, and we really have to justify a failure of their previous therapy to justify moving on to one of these newer products. Patients reported reasons not to change. So not every patient uptakes these new products. It could be cost. It could be comfort with their current product. They just trust it. They've been using it for a long time. They may feel like their response is great and they don't really want to change it. In the case of factor VIII, they may feel like the decrease in the number of infusions per month is just not enough for them to make a change. What we hear frequently from patients, even though there's not a lot of PUP data out there, is the risk of inhibitor development. And that scares patients. I'd say across the board. And some just want to wait and see and let somebody else try it first, and maybe they'll have the uptake of that later. So in summary, introducing a new product to your practice and to your patients requires planning and follow-up. Real-world experience shows you that you can maintain effective protection with less infusions with these new products, but we know that each person should be evaluated individually when determining what their specific optimal treatment is. And going back to education is a key to success, not only for the staff, but for the patients as well.